survive until death. Approximately 70% of these are low-grade benign behaving tumors. About 30%, 25% are a slightly higher grade, more aggressive. They tend to recur. They need radiation therapy. And they're a very common tumor. They're found frequently, incidentally, for example, after a concussion, CT scans done for other reasons. And lo and behold, there's a tumor that looks like a meningioma. Most of the meningiomas at diagnosis do not require treatment. So if the patient is asymptomatic, they don't have symptoms specific to the tumor site, and there's no documented growth, then there's no role for intervention. The patient can be safely observed.
Okay. I think you answered maybe 2 questions there. That's good. What is the most common misconception that people may have about meningiomas, if there is one?
Yeah, I think there's, when you tell a patient that they have a benign tumor, they think that, surgical treatment will be curative, and that's not always the case. And we have options for treatment. So if we're following a patient who's asymptomatic and they either become symptomatic or we have documented radiographic growth, then there's a consideration for intervention or treatment. And there's different forms of treatment. Treatment includes surgery, radiation therapy, or radiosurgery at diagnosis. And each of those forms of treatment has a different risk profile.
Okay.
When the tumor recurs, and even 50% of benign tumors totally excised will recur 25 years after diagnosis. So the key thing is that if you treat a patient with a benign tumor, they have to be followed essentially for their lifetime to rule out recurrence.
Okay, great. What are common, if there are, common symptoms?
So the most common symptoms for an adult patient with a brain tumor of any type are headache, seizures, progressive focal neurologic deficit. Well, what does that mean? That means if the tumor overlies your motor cortex, you develop weakness on the other side. If it's over your sensory cortex, you develop sensory symptoms. If it's over visual, you develop visual. And then the other one is change in personality or behavior. And that relates to the fact that the frontal lobe and temporal lobe are large parts of the brain, and they control mood, insight, judgment, personality, and behavior. So if you have a big tumor pressing on your frontal lobe, you'll have the so-called frontal lobe syndrome, which is apathetic, amotivational state, depressed mood, and those are the kind of symptom complexes that the patients show up with. So every headache is not a brain tumor. A headache that's present for 2 weeks, worse in the morning than the evening, associated with nausea and vomiting, that's not normal.
Excellent, excellent. And if there are any, top risk factors for meningiomas?
So there are risk factors associated with the development of meningiomas. The majority, overwhelming majority, 90% or greater, are sporadic, meaning we don't know why they occur. As I mentioned, majority are benign, but there are risk factors. Prior radiation therapy exposure, and this initially came from an experience with the repatriation of the Jewish population after World War II, where there were high numbers of individuals in camps and they developed fungal infections of the scalp because of bad personal hygiene. And then we realized that 20 to 25 years later, they had a much greater likelihood of developing meningiomas. Fast forward now with childhood leukemias, for example, where the children are irradiated prophylactically between the ages of 3 to 7 if they have a leukemia. And now there's a national registry for those patients to be entered into, understanding that there's a 25-fold risk increase for the later development of meningioma. There are other associations with certain genetic syndromes like neurofibromatosis, non-causative links like breast cancer. Breast cancers are very common. Meningiomas are much less common, but they have similar genetic abnormalities. Doesn't mean if you have breast cancer, you get a meningioma or vice versa. There's an association with thyroid tumors, association with fertility treatments and an association with a family history, like 2 first-degree relatives with meningiomas might put you at a higher risk later in life for being diagnosed with one.
Okay. And I think you answered this briefly, how are meningiomas usually diagnosed?
Yeah, so it's, I would say that I don't know exactly what the distribution of discovery by chance versus symptomatic discovery is. I would say currently that the greatest proportion of patients are discovered by chance because of the wide availability of modern imaging, particularly with magnetic resonance imaging studies done for other reasons, that these tumors are frequently discovered.
Great, excellent. And the last one you may have answered somewhat, is surgery the primary treatment for meningiomas? What are other options? You want to just briefly?
Yes, so surgery is still considered the primary treatment for meningiomas, especially when the tumors are symptomatic. So if you came in with a seizure, first-time grand mal seizure as your initial presentation for meningioma, the meningioma itself is not the cause of the seizure. It's the effect of the meningioma on the adjacent normal brain that's causing the seizure. So if you remove the inciting culprit, so to speak, then you can reduce the likelihood of future seizures, and you can reduce the likelihood of an epilepsy syndrome, which means recurrent repetitive seizures in spite of medication. So there are some locations where surgery, like in the skull bases, can be very complicated and associated with a much higher risk profile than a meningioma that's on the surface of the brain up in the what we call the cranial vault. So basically imagine above your ears all the way up. And so those ones are less risky than the ones that are in the base of the brain where the arteries and nerves are entering and exiting the base of the skull.
Well, that's it. I covered all the questions, and we got much more than we needed for the quick social bites we're going to do, but I got plenty for the articles.
Well, I have one question. Mm-hmm. Just one. I just want a clean statement. Why should a person receive brachytherapy treatment at Baptist South Florida? So, what makes Baptist South Florida? Like just a brief statement. Baptist South offers the most experience, something like that.
Right. So, I think one of the advantages we have at Baptist Health with the Miami Cancer Institute is the wide variety of treatment options and treatment delivery systems. It's unlike any place in the world that I've seen in terms of the radiation therapy facilities. And until I arrived, they didn't have anybody with experience doing brachytherapy. And so I'm happy to be able to add to the armamentarium of options for treatment for patients.
Fantastic. And we're happy you're here too. Anything else, guys?
I did want to add one more thing. Dr. McDermott, I know you are extremely well published with meningioma research. Can you tell us a little bit about how many papers you've published with regards to meningiomas?
Well, I think one of the advantages of being in an academic, there's pros and cons of being an academic center. The pros are that you get to teach the future neurosurgical neurosurgeons of the not the world but the country. So you're continuing your specialty. You get to be involved in clinical research more than basic science research, and you usually get the most difficult cases. So the easier ones, this is not always true, might tend to be done at a community setting, and with that huge experience that you collect over time, you have the opportunity to look back, see what you've done in the past, how can you make it better to improve the care of the future patients. You can be involved in clinical trials that provide unbiased information about the results so that patient selection by the doctor. So my favorite thing to do is brachytherapy. Therefore, all my patients get brachy. That's not a good patient sample. So I think that, over the years, I was able to, I had an interest in it. The con was that it was as my family will tell you, a pretty big sacrifice for, working hours, but I loved it. I mean, I don't regret it. And my wife has asked me whether, other people have asked would I do it over again. The answer is yes, in a minute. And I think the great thing about surgery is you can have a major impact on somebody's life, and 98% of the time it's positive, 2% of the time it's not. And when you don't remember the good cases wherever the outcome went great, you remember the cases where something went wrong and there was a bad outcome. And in neurosurgery, a bad outcome can be really bad. So those are the cases that you go to bed at night thinking about, wake up in the middle of the night, wake up in the morning in the shower, driving to work, and it beats on you for, depends, weeks, months, but it never leaves. You can remember like yesterday when you had to walk into that room and see that patient every day that was changed forever because of some intervention. So it's tough. But on the other hand, there's always, 98% of the time it's the other way around. And the patients are, I think, terrified with the thought that you're going to operate on the thing that makes them human. Animals, dogs, cats, you name it, can walk around, do anything, but they can't communicate like we do. So if you think that you're about to be operated on the organ that's responsible for what makes you human, your vision, your speech language function, your motor function, sensory, memories, moods, all those things, it's like, it's terrifying. So it's hard for the patients to realize that it's safe, and the majority of the time that it works out really well. And we don't save patients' lives every day that they think we do. We're extending their lives and making them better. But it's rare that they go into the operating room and if they didn't have the surgery, they were going to die immediately. So, I think one of the ways that we try and deal with that is to use a little tiny bit of appropriate, humor. It's okay to actually these days still put your hand on the shoulder of the patient, reassure them and all that stuff, which is the human part of the art of medicine. And the science part is all the technology and robots and instruments and lasers, et cetera, et cetera. So, but yeah, I think this year I might go over 500 peer-reviewed papers. Edited a couple of books on meningiomas. The last one took me 2 years to get through, but it's done. I think it's thanks to all the co-authors, it's a fabulous product.
Wow.
John, that's the book that we mentioned that we definitely want to mention in the blog post.
It's remarkable that you find time for all that writing as well.
Yeah,
that's just remarkable.
Seriously.
You are committed. And that's
great. And it's already on his profile, so we can just link directly to the book. Yeah.
No, perfect.
That's awesome. Super cool.
Very good.
Did we also, John, I know we just have about 1 more minute. So is there anything else, Dr. McDermott, that you want to add?
No, I think I have some PBS interview next, right?
Oh, cool. Oh. She reached out. Good.
All right. You're in high demand here. All right.
Yeah, he is. Yeah. That is awesome. You're going to be sick of talking about meningiomas because I think the interview, is it about meningiomas, brain tumors?
No. Well, you got warmed up here.
Yeah.
Yeah.
Thank you so much, Doctor. Appreciate it. Everything.
Thank you.
Take care.
Who's that, George? Is that your son?
Yeah.
His
daughter? This is my daughter.
It's his daughter. She's only like, she's 6 months, right?
She's not even a year old. And Katie was kind enough. Katie's godmother, Katie, because she donated all the clothes that don't fit her daughters anymore. And I get all the redhead.
We have truckloads. I have truckloads of stuff that I can give to George.
Whenever you bring a baby